Good morning, it's Dr. Rutledge, and I'm going to talk to you this morning about some of the preliminary data for the upcoming mini bypass, one anastomosis gastric bypass first international consensus conference, which is going to be held the 18th and 19th of October 2012 in Paris at the Marriott at the Charles de Gaulle Airport, to be followed on the Saturday the 20th after the first 2 days of the conference with demonstration live surgeries with Dr. Katie, Dr. Gaulle, and Dr. Shishish, and we're excited about that. In preparation, we've been collecting data from our experts who will be participating in the conference, and those of you who are getting ready to come or thinking about your responsibilities having to complete our survey forms. We thought we'd give you some good early feedback. Basically, this morning we're going to go through the numerical data that's coming in from the first 15 surgeons that have filled out our forms, and what we're looking at is numerical assessments of the performance and outcomes of the band, the sleeve, the Roux-en-Y, and the mini bypass, or the one anastomosis gastric bypass. And what we'd like to know is, asking these experts with these different operations, what can we expect? What are we talking about? What are the outcomes, complications, operative times, etc.? What bougie size is being used? These are the questions we're going to ask. And then we'll be part of the voting and discussion in Paris as we provide what we think will be a suggestion of best practices, or maybe open controversies in the area of the new mini one anastomosis. The body mass index tended to be highest, on average 47 for the patients selected for the mini bypass, one anastomosis bypass. Roux-en-Y 37, sleeves 35, and bands the lowest at 29. So at this point in time, in 2012, the band is being selectively applied, it appears, for a lot lighter weight patients, and MGB being selected for heavier patients. Operative times are interesting. Basically, the band seems to be the shortest, about 30 minutes. Sleeve about 45 minutes. MGB 65 minutes. And Roux-en-Y 90 minutes, about an hour and a half. Blood loss, again, is kind of similar in going from least with the band, most with Roux-en-Y, but all under 100 cc's, so it's not like these are bloody cases, it appears. Bypass limb length in the mini bypass or one anastomosis bypass is around 2 meters for the majority. And length of stay is pretty close. Bands average about 1.5 days, and the sleeve, the Roux-en-Y, and the mini bypass, one anastomosis bypass, are all about 2.5 days. We did ask about the percent of the population which were diabetic, and in the Roux-en-Y and MGB groups, it was 20% for the Roux-en-Y and 26% in the MGB. Bands only saw about 4% of their caseloaded diabetic, and 11% of sleeves were diabetic. The resolution rates, again, this is preliminary data, fairly low for bands, only in the 10 to 15% range. Sleeves reported, and again this is early, small amount, but 48%. Roux-en-Y's seems to be about 60%, and reported for MGB is 89%. Stricture rate, very low for MGB, about 0.3%, and 1.5% for Roux-en-Y. Leaks seem to be lower in the MGB group. Hospital stay for leaks after MGB seem to be fairly short, 9.5 days, compared to leaks for Roux-en-Y and sleeve, which tend to be 20 to 30 days for both of those. We also asked about preoperative reflux rates, GE Reflux, and what we found is pre-op reflux in the band and sleeve patient was reported in only 7 or 8%. On the other hand, in the Roux-en-Y and the MGB patients, between 17 and 25% were reported as pre-op reflux. Interestingly, these numbers switch and flip-flop post-op. So although band and sleeve patients are reported to have GE reflux at very low rates pre-op, post-op they're reported in 25 to 28% of people in the band and the sleeve. So they go up by a significant multiplier after the band or the sleeve is performed, according to this preliminary data. In contrast, after the MGB or the Roux-en-Y, the rates of GE reflux declined precipitously, going from 20-some% in the MGB to 3% post-op, and 17% in Roux-en-Ys down to 7% post-op. And that's been my experience as well. We asked for average follow-up in the survey so far, and it's all about 4.5 years, band up to 5 years follow-up on average. And then we asked some of the other kind of standard questions. What's the excess weight loss? And what we found in this report, again, this is preliminary, a lap band percent excess weight loss is reported at 35%, sleeve 50%, Roux-en-Y relatively low 52%, and in MGB 78%. Weight loss failures was also requested. They reported 22% failures in bands, 14% failures in sleeve, 8% failure in Roux-en-Y, and 3% failure in MGB. We asked what percent they had excess weight loss, greater than 50%, 89% of MGB, 85% Roux-en-Y, 79% for sleeve, and 35% for band. We asked what percent had ulcers, and it's very low for band and sleeve, 0.3, 0.6, and for MGB at 0.9, significantly higher for Roux-en-Y at 1.6%. Bowel obstruction was also significantly higher for the Roux-en-Y at 1.8%, or about 2%, and about 10 times lower in the other groups that were not Roux-en-Ys. We also asked for revision rates, and lowest was MGB at 2%, Roux-en-Y 4%, sleeve 6%, and band was 18.6%. This is all preliminary numbers, but it gives you a taste of why we are canvassing our participants. Imagine that this data becomes confirmed with a large number of other surgeons. It gives us a reason why many surgeons are choosing the mini bypass or the one anastomosis bypass. If this number was confirmed, what it would say quite simply is that the MGB is a short, simple operation, much more durable, much more effective, tends to resolve gastroesophageal reflux, have the best weight loss, the low rate of bowel obstruction, low rate of ulcers in comparison to Roux-en-Y, a low rate of revision, and then when revision is necessary, it's easily done. So we're collecting this data, we'll be discussing this and looking at this further at the Paris meeting, and we hope to keep you up to date with this and other videos. So thanks for tuning in, and as more data comes in, we'll report some of this back to you. Thanks very much.